Hello there. This is Asin Hussain. I'm an assistant professor in ophthalmology at Dalhousie University in Nova Scotia, Halifax. And here I shall be discussing the management of eyelid and lacrimal trauma. So many ophthalmologists, regardless of their type of practice, may be called upon to assist in the management of patients who've sustained acute eyelid, lacrimal, or orbital trauma. And there are certain principles which have to be applied whenever you're assessing a patient who has sustained a periocular or even a globe injury. It's important to be systematic so you don't miss things, very important. And I think from personal experience and from teaching residents, part of that is also dependent on how you're referred the patient. So if you are going to the emergency room to see a patient who's had a history of trauma, it is important to be aware that the patient may have other injuries, systemic injuries, which are life-threatening, and the patient may need resuscitation. And your role might be secondary to that. And you may have to delay your assessment till the patient is stable. If the patient is referred from an outside center, over the phone, it's sometimes tricky to know all the information. So my advice is be as sure as you can there is no globe rupture. You do not want a patient transferred who might be delayed or may have unnecessary pressure on their eye who has an open globe. And finally, of course, if you're seeing a patient in clinic who is generally stable, assuming they're stable, then of course that patient is likely to be the type of patient who you're able to examine more thoroughly. That doesn't apply to children, of course, all the time. In a child, you may have to have a very low threshold for an EUA. So as I said, first things first, rule out life-threatening or sight-threatening injuries such as an open globe. And your approach really is to, first of all, maximize the results of primary treatment, and secondarily, to minimize the need for secondary reconstruction. So when you are seeing a patient, let's say you see a child and you're not sure, I would say, if you can early on, get the patient to be nail by mouth so that they can have an EUA early on or as soon as is feasible. Always remember that your functional concerns override cosmesis. So the critical thing, first of all, is to get a good history. Of course, in situations where a child has had an injury that's unwitnessed or a patient who's had a self-inflicted trauma, that history is somewhat unreliable. You also have to be aware that the mechanism of injury is very important. So a sharp trauma may well have a foreign body involved, which may not be visible anymore. You should have a high index of suspicion for performing imaging in those patients. In a blunt trauma situation, you may need to, of course, do a CT or imaging to also guide you further. And the type of injury that you see with blunt trauma and sharp injuries are somewhat different. And finally, with bites, with animal bites, normally we see dog bites, which is how I see the majority of periocular trauma. The mechanism of the injury is also somewhat different. So I'm also going to talk about primary repair of injuries briefly, and that is always superior to secondary repair. It is very important to document all your injuries very carefully, because this could end up being a medical legal issue, and lawyers and so forth will look at your documentation if there is a claim involved. Important also to always be thinking of the whole patient. So in an injury involving dirt or debris, you'll need to think about antibiotics. You'll need to think about immunosuppression on the part of the patient, and you'll need to think about checking tetanus status. So this is probably one of the worst dog bite injuries I've seen, which was here in Halifax, of a child who was just bringing back a neighbor's dog, and the neighbor's dog decided to have attack the poor child. Referred to me from an outside center, so very important to be aware again of no globe injury. But this young girl sustained upper and lower avulsion injuries of the eyelid from the medial canthus, which is typically what happens in a dog bite, because the jaw of the dog attaches to the periocular area and pulls. So you don't really get a globe penetration with dog injuries. That's very, very rare, although you should always be checking for that. It's more likely that you've got a ripping injury involving the medial canthal area. So what do you have to do in these situations? Well, first of all, assessing the patient. I would say that you need to classify, let's say the patient does not have a globe injury, and for all intents and purposes, the orbit is fine. Systemically, they've had no injury. So you're just focused on the eyelid and what's happening around the eyelid. So you need to classify your injuries. You need to look at, well, is this a margin involving injury? Is it an extra marginal injury? Is there tissue loss? And is there avulsion of tissue? So in this patient, you could argue, well, on the upper side, you can see there's sort of a laceration there. That's an extra marginal injury. The eyelid margin, at least in the main part of the eyelid, looks okay, but medially you can see there's been an avulsion and even possibly loss of tissue. And that's going to guide your kind of management strategy. It's a child. The child may let you examine do the examination at the slit lamp. If you're not sure, maybe if they're older, they let you do a little probing. But honestly, I wouldn't push it. They've already been through enough. And I would say to you, if you have a young child, under 16, even though they seem brave, I would say just say that, look, we'll just have a look when you're asleep and we'll fix whatever's necessary. But have low suspicion of a canalicular injury in these cases. And of course, this patient has both upper and lower canaliculi involved. So you have to counsel the child and the parents, of course, that there will be repair of the tear ducts, and also warn them that there's always a risk that when there's this sort of injury, you may not be able to repair them completely, resulting in the worst case scenario, tearing. Which again, there are treatments for, but those would be secondary surgeries that you would do later on. So how would you approach this patient when they're asleep in the OR? So of course, do the examination. I would do a globe exam again, dilate the pupil, check the back of the eye, make sure there's no conjunctival laceration, make sure there's no exposure of the extraocular muscles, do a force duction test, and make sure that you're happy with the orbit. And like I said, classify your injuries into the 4 types. Again, these are not mutually exclusive. A patient may have more than one. And then your repair is going to come down to your eyelid closure principles. That's a separate talk in itself. However, if the eyelid margin is involved, you will have to repair the margin, and that's in your manuals. You'll find that you'll need to do buried sutures at the gray line. Some people also place a lash line suture. I do a vertical mattress buried suture at the gray line and the lash line. And then I do 3 buried sutures within the opposing the tarsal plate. And then I close the skin and orbicularis. For the extramarginal injuries, if you see orbital fat, the septum has been involved. That will need thorough exploration and debridement possibly. Try not to excise fat unless it's absolutely necessary, because you may cause asymmetry in the appearance of the lid compared to the other side. Don't cause traction on the fat, that can cause bleeding. And don't confuse the fat with the lacrimal gland. We always tell people and residents who are assisting in surgeries that when you're doing ptosis surgery, be aware that the lacrimal gland can be easily confused with your lateral fat pads. Like I said, with this patient needed canalicular repair. And I would say to you from experience and from my training that if the upper and lower canaliculi are involved, you should really be thinking about bicanalicular intubation. And I actually do that now for both single and dual canalicular injuries. Why do you say I do that? Well, to oppose the medial canthal structures well, to hug around the globe is difficult. And really to get that best apposition, I find that having the bicanalicular intubation gives you the best apposition of the medial canthal tendon and the best cosmetic result for the patient. And that's what you're trying to achieve with the, like I said, with the bicanalicular intubation. So this is as a child, I'll just give you an example. This is during my fellowship. I think I was in my 2nd year, so the staff just said, go and have a look and just do what you need to do. So this is just a close-up. The patient also had some facial injuries. Thankfully, no other systemic injuries. Globe was fine, orbit was fine. But as you can see, complete avulsion of the lower lid. Of course, the canaliculus is involved. And this patient, who I performed in the plastic surgery OR while the plastics people did the facial lacerations, I did a bicanalicular intubation with Ritalin tubes, which is what we do at Sick Kids in Toronto. And I did the repair of the lower lid, and he did very well. I mean, he no tearing. This was, I think, 4 weeks following surgery. So in summary, I would say to you, be systematic in your approach to all eyelid and lacrimal drainage system injuries. Your priority is to rule out the globe and systemic injuries. Primary repair is always better than secondary repair. Think of the patient as the whole patient. Don't just focus down on the eye. We're very good at what we do, but think of the whole patient and have a very, very low threshold of imaging and exploration for either foreign bodies or deeper injuries than you think. And there have been case reports of patients having intracerebral foreign bodies, which have been missed because, the kids sometimes, don't tell you the whole story. And so have a low threshold. Remember CT first, because if there's a metallic foreign body, you don't want to be doing MRI, but you will not be able to see an organic foreign body on a CT. So you will probably need an MRI if you think wood is involved, or at least an ultrasound in the initial period. Okay, that's the end of that case. Gabby, do you have any questions? You're on mute, yeah.
I just have a couple of questions in terms of timing of eyelid repair.
Yeah.
I was wondering if you could comment on practically what your approach is. I know that there's guidelines mentioned in textbooks, but practically what do you do, and whether or not the timing of the repair changes if you suspect a canalicular injury. So let's say if there isn't an area suspicious for canalicular injury, do you let it go a little bit longer, or are you a little bit more lenient?
Yeah, that's a good question. And I would say that it varies depending on people's practices. I would say to you that if the canaliculus is involved, let me start with that, then the sooner that's repaired, the better. Some people have argued that, well, if you leave it a few days, the swelling goes down and it's sometimes easier. But I actually find that from experience, sometimes it's actually harder because the cut end, the nasal end of the canaliculus can start to retract. And then you'll find it very difficult to find it if it's a very nasal injury. If it's a margin involving laceration, I would say you should do that as soon as possible, because if that starts to heal, so I would say within 5 to 7 days that should be done, because if you leave it longer than that, it'll make it more difficult for yourself. Non-margin involving injuries, you could probably leave for up to a week, and some of them, even healing by secondary intention, they do remarkably well. As long as that, you've got a good history with no foreign body, no sign of deeper injury, then you could probably do that. But generally speaking, as an oculoplastic surgeon, here in Halifax, there's 2 of us. And if there's a periocular injury, one of us goes in usually and repairs that within a day or 2. That's what we're doing in Halifax. But I appreciate that's not possible in every center, especially if the patient lives far from a tertiary referral center. It's most important to stabilize to repair the globe and any life-threatening injuries. And then the eyelid injuries, whenever it can be got to, then that's fine.
And then one other quick question, just in terms of the probe that you use when examining these patients under anesthesia. Do you prefer to use Bowman probes? And is there a specific caliber? Like, do you try to just dilate the punctum and use the larger ones for fear that thinner ones might create false passages? And whether or not there's a role for a pigtail probe in your own experience?
So I would definitely say to you that the pigtail probe is a no-no, complete no-no. Actually, that was discussed recently in a talk by Dr. DeAngelis, and it's a very dangerous probe because you can actually cause inadvertent iatrogenic damage to the uninvolved canaliculus. So I would say never use a pigtail probe. There are now better methods for you to find the cut end of the canaliculus, such as installation of fluorescein or some Helon or Discovisc, which can sometimes help you, or even air sometimes can help you, bubbling through sort of a sea of liquid there. Your question about what probe to use, I would say that either a 0 or a number 1 probe. It's a good point that if you use a small probe, you might cheese wire, but really all you're trying to do is be very gentle with the cut end of the eyelid and trying to see if you're able to see your probe from one side. I wouldn't be doing a nasolacrimal duct probing with these probes in the trauma setting. I would just be checking the eyelid part. And, you know, a number 0 or number 1 probe is usually good, so dilate and do that. But be gentle. If you're forcing it, then just don't do it and assume there's an injury, and then check in the OR when you're with the patient.
Thank you.
No problem.